Washington is full of noise, but here we cut through it. I'm Ryann Hill, your trusted voice on healthcare, aging, and disability policy. On Mic'd Up, I sit down with the people driving change to share their stories, insights, and strategies in the Beltway and beyond. Welcome to Mic'd Up with Ryann Hill. Welcome back to Mic'd Up with Ryann Hill. I'm Ryann Hill, and I'm so glad y'all are here. This show is about cutting through the noise in Washington to bring you real conversations with the people who are actively shaping healthcare, aging, and disability policy. Today, I'm joined by two exceptional leaders working every single day on behalf of physicians. We have Christina Epperson from the National Medical Association and Nina DeJonghe from the Society of Teachers of Family Medicine. I need to tell this quick story about how I've been trying to connect these two ladies, and the first time we're connecting is on the podcast. So Nina, spoiler alert for the audience, is one of my best friends. For folks who follow me on LinkedIn, you'll see her everywhere on my LinkedIn. We do everything together, and it's been that way for some time now, but she is one of my favorite health policy lobbyists and just brilliant. And my first time having a conversation with Christina, I said, she sounds like Nina. Like, she's saying some of the same things that I hear Nina telling me about all the time when we're like on our FaceTime rant conversations, or she's talking about what's happening in the physician medical policy world. And so I said, Christina, I need to connect you with my best friend, Nina. You guys would love each other. And then my firm, we co-hosted a holiday party with this phenomenal group called Black in Health Policy at our office. And Christina came and had the best outfit. I can't stop thinking about that red tartan blazer you had at that holiday party. And I said, oh man, you're here, but guess who's not here? Nina, because Nina was out of town.
Yes.
And so you guys have been ships in the night. And I'm so grateful that we could have you guys on the podcast today, because I think that not only is there a lot of synergy in the work that you do for your respective organizations, but I think that like you two are just brilliant advocates and just fantastic at what you do. And I think that the audience who listens to this podcast will be just, better. They'll leave this conversation with a better understanding of what's happening in the physician provider community, what's going on. I feel like we talk a lot about, healthcare, aging, disability. We've had hospitals on, we have people in the aging space on, we have a lot more awesome guests coming forward soon. But I think it's you guys' viewpoints are going to be so important to really tie everything together. So let me stop talking. That said, I want to start. I would love for each of you to briefly introduce yourself, your organization, who you represent, and your role within it. Christina, let me start with you.
Yeah, of course. And again, thank you so much, Ryan, for having me. I'm so glad to be here with both of you. My name is Christina Epperson. I am the Health Policy Manager for the National Medical Association. And the National Medical Association represents the interests of the 55,000 Black physicians in the country. And so through that, I work with them to make sure that I make them look like rock stars when it comes to policy. They have the stories, they have the experience. I'm sure that you will hear me repeat this a lot over the course of our time together on this podcast today, but they have all the experience that we need to be taking to the policymakers to amplify and make sure that the policy is crafted for physicians who are serving the patient. So again, really happy to be here and looking forward to the discussion.
Awesome. Nina?
Yes, my name is Nina DeJonghe. I'm the Director of Government Relations for the Society of Teachers of Family Medicine, but I also represent the Council of Academic Family Medicine. And thank you, Ryan, for having me on today. Very excited about this. So to start, the Society of Teachers of Family Medicine is a national organization, and we focus on advancing family medicine education, leadership, scholarship, and advocacy across the entire training continuum. And as my role as a federal lobbyist for the Council of Academic Family Medicine, not only do I represent the teachers, the faculty, it's also the department chairs of the universities, the residency program, directors across the country for the family medicine residency programs, as well as the different researchers and behavioralist as well. So it's a whole gamut of things.
That's a lot.
I know, it's a lot.
You guys know.
I know, I'm like, that's a mouthful.
You guys know that meme that's going around where it's like, what does your best friend do for work, right? And I feel like I'm privileged so that I can give like the general parameters of what Nina does. But every single time I hear more about what the day to day, I'm like, oh my gosh. And that's why I really wanted to have this conversation, because I feel like there's so much going on. And I think that like you ladies, like your finger on on the pulse. Maybe we need a cinnamon roll or a drink. I don't know.
Both and.
Well,
Both and. So why don't we zoom out for a second? I would love
yeah.
if you guys can talk about from where you sit working on behalf of physicians, how would you describe the current federal legislative and regulatory environment now that we are almost a year into the second Trump administration?
Yeah. It's been tough for sure, and we've been faced with a lot of real tension. And I think that while there's broad recognition that the healthcare system is strained, especially as we talk about primary care and the physician workforce, a lot of the policy solutions remain fragmented because we have not seen full term spending. We have been operating on, I don't know what continuing resolution this is, but we know with any continuing resolution, that is not ideal when we talk about programs and sustained funding. So that is something, that our docs have been trying to navigate, and try to sift through because it makes their jobs even more difficult when you talk about from a
Mhm.
training perspective, as a residency director, just not knowing in recruitment, for
Mhm.
residents that are coming in to their first time in residency without concrete, funding. It's hard to recruit a class to come in, and as a resident, you're there and you're faced with all that uncertainty. So it's been a lot, and especially from the regulatory standpoint as well. We've seen a whole host of different regs coming out left and right, especially obviously last year. It's been difficult too, I think, just to stay afloat and figure out, prioritizing what do we respond to right now. And I think I'll speak for myself, but being a lobbyist in this space, I think the last year and some change has definitely felt like we've been a little bit more reactive, and it's been a little bit more difficult to be, proactive.
Mhm.
I would
Christina,
definitely
your
agree
thoughts?
with that. Yeah, I would
Mhm.
absolutely agree with that, especially the last part that you said about being reactive instead of proactive. And I
Hmm.
think as organizations, we try to be as proactive as possible, especially when it comes
Hmm.
to getting out information that is specifically pertaining to healthcare.
Hmm.
And that's really hard to do. I would describe the last year, and I still can't believe it's only been a year. It feels like it's been 50. But I would describe it as scary and lawless, to be honest.
Mm.
I think something that I always enjoy about working with the physicians is they're the people on the ground. They're supposed to be the
Mm.
people that are informing the policy because science is supposed to drive policy. But right now, that is not currently happening. We are having people that have no experience in certain spaces, that have no background in, for example, vaccines, spewing information that is just completely untrue. And so it's hard when our physicians are going to their patients and trying to have these discussions. There's a lot of backlash with, well, if the government is saying this, why would I believe
Mm.
you over the government? So I've been hearing a lot of, especially with our family medicine physicians, our pediatric physicians, how hard it's been when you have to deal with especially children and convincing
Mm.
their parents of the different things that are going on and talking them through it. So I think my perspective is more so from, especially because we have so many different sections, it's not like I'm just dealing with one disease state or one
Mhm.
a specialty of medicine. So I hear it all, and it has been very all over the place in terms of what I've seen and what we've had to deal with.
Yeah, I think those are good points. And just to go back again around, policies should be driven by science and,
Mhm.
evidence-based outcomes. And that is not the case. So one of the things that we talk about consistently with the physicians too, in questions that we'll get, how do we translate this research in a way that
Mhm.
Congress, these staffers, et cetera, are going to listen? We have definitely had to change our strategy. No longer are we coming in here into the office and saying, using this data point,
Mhm.
and this data point over here. Now it's like we really have to draw from the stories and experiences
Mhm.
from the physicians on the ground and bring those patient stories to life, because that is almost the only way we're able to find some sort of synergy and to
Mhm.
kind of connect those dots there, and to show succinctly, like, if we do not have X, Y, and Z program, this will impact
Yeah.
your district by, this amount, and really having to make it very granular, which we already did. But now
Mhm.
it's just been so difficult being a lobbyist or being an advocate in this
Yeah.
space where no longer is the evidence relied upon in that go-to source for making important decisions.
So let me follow up with you on that one, Nina. I think, I know you've been a lobbyist for some time. I know you as well, Christina, being in this lobbying policy space. I feel like as a lobbyist and an advocate, I feel like always having to think about new and creative ways to get our points across, right? Like when someone asks me what I do for a living and I don't really want to talk to them, I always say I'm in sales because that's what we do, right? Like we sell thoughts
Yeah.
and ideas, right? We
Yeah.
sell ideas and visions and policies,
Mhm.
and I think Nina, you were starting to say that like the tone and tenor of what we've seen, not only since the start of
Oh,
this congressional session, but this administration has been very different. It has led you guys
yeah.
to have to think creatively about how
Mm-hmm.
are you getting your point
Absolutely.
across. Can you guys talk
Yeah.
a little bit more about that, about like, what's broken through the conversations? What arguments or positions have really made a difference in this past
Mm-hmm.
year or so that you can share with the audience, and especially for folks who are trying to figure out how do they change their game plan, right? Like what they've leaned on, what they've done forever. What have you guys done or seen breakthrough that you can share with others?
I would say that my catchphrase, especially since I've become an advocate and become a lot more active, I'm on the Hill and everything, is that facts tell, but the stories sell. And so when you have the
Mm,
actual
that's
physicians
good.
going up there, or if I'm talking about something on behalf of the physicians, the three of us, we can go online, we can research, we can go to the JAMA articles and all this other stuff, but we're not in the room with the patient saying that, hey,
Mm,
I have been working with this patient for the past 10 years and this has worked, but now because of this policy, they no longer have access to that. And because of that,
mm,
now they may lose access to the medication that's keeping them alive. And especially when you're able to relate that to say, that this congressperson maybe had a wife or a daughter or somebody that may have had a health issue. It may not be the same issue, but that
mhm,
connectability piece, regardless of what side they're on, has always been a huge success point for me. I'm not saying that it always works, but especially
mhm.
when trying to educate the physicians themselves on how to be better advocates, or when I'm going on behalf of the physicians, telling those stories have always been the biggest point of impact to me. Because it just seems like, especially, you can leave the facts after. I can have the percentages and the data points, but if you're trying to say that in those 15-minute meetings, everybody's eyes are glazing over. They
Right.
want to hear how this is really,
Yeah.
affecting. And the other thing is, being an organization that represents Black physicians in some offices, we have to, as much as some people feel that we do, some people feel that we don't. Some offices, you got to kind of change your language and not use equity, not use
Mm,
diversity. We have
mhm,
to say
Yeah.
mhm,
rural. We have to say,
mhm,
you have to really just know who you're going to talk to, or to be quite candid, sometimes you have to know even that sob story about the little girl who needed the healthcare coverage, that may not work either. You may have to start talking about the
mm,
dollars and how it's going to affect
Yep.
mm,
them from a monetary perspective in the district. So
mhm,
I would
mhm,
say that the change in strategy has been a lot less linear, and has
mhm,
been a lot more of knowing who you're talking to, knowing who to send for that specific issue, because you might have the pediatrician that has the sweet sob story, but that person just really might not care about that sob story. So you just
mhm.
need to know who to send, what exactly the points are to hit on, and then what's important, as I always say to anybody that is trying to become an advocate, because anybody can be an advocate, is follow up, follow up, follow up, follow up, follow
Yeah.
up, follow up, follow up, follow up. I learned from
And
somebody
then
that
follow up
I
again.
enjoy, and then follow up again. Somebody that has really, helped me in this advocacy space told me that advocacy is not a one night stand. You need to date
Oh,
them.
you
You
are
need to
really
court
serious.
them.
Now, hold on now. I need to
Please,
write some
please.
things.
Okay. We got to go on some dates, okay? We
Good.
cannot just be hit and
Good.
quit it. We have to
Yes.
keep it
I
going.
love
So
this.
that
I love that.
that's the frame of mind. I hope I'm not being
Yeah.
too crass, Ryan,
No,
but
you're absolutely right. And I just want to drill down on a couple points because I think that, when we as advocates are representing organizations and people where this is their livelihood, right? Like this is really truly life and death, right? Like
yes.
your health especially is, one of the most important things you will ever have. And oftentimes, right, as individuals, we don't sort of recognize the importance of our health until we are missing an aspect of it, right? To the
Hmm.
point that we see all the time. In healthcare, aging, and disability, when I'm talking to, my colleagues, my clients, it felt like there was this hesitancy in the initial stages of 2025 to change language, right? And I felt like I was doing a lot of fruitful explaining of like, hey, we need to, instead of using this word, we need to use this word, right? Instead of, we're not changing our strategy, we're changing the way that we're communicating our priorities. And I felt like, it took a little bit of time for some folks to get up to speed or be willing to do so. I think there was this feeling like if we don't say equity, then are we leaving, right, our values on the table? If we don't
Yeah.
talk about health disparities, are we leaving our values on the table? And I think that we've gotten so a much better grasp as a whole on being willing to do that, to talk about rural health, right? And when you talk about rural health disparities, to flag, some of the stories and the dollars when I'm taking advocates on the Hill or helping them navigate a different policy outcome or even write a comment letter, right? I'm like, well, let's look at the language that this member of Congress has used. Let's look at the language that we see on the government websites. Let's lift the language that's in this proposed rule and use that as our foundation in order to make them care about this topic, right? So if it's dollars, if it's cost, health disparities and health equity is costly, right? Like not addressing disparities costs a lot of money. The ROI is there. And I think it's really about a reframe that I think is so important in advocacy, because you can't just go in and copy and paste the same message because it's not going to land. And you have to be willing to reframe and to pivot and to stay true to your core message, but use a different wording in order to get the attention of the folks that you're trying to get the attention of.
Absolutely. Absolutely.
Yeah. You made some great points. Both of you made great points. And I think last year, specifically when all of the executive orders came down, right, and we were talking about DEI. So changing the language, changing the framework. And I think that it obviously was difficult because also changing those words, like, are we changing the meaning associated and attached to these things? Does that mean that we are now diminishing the value of, the work that we are trying to do? So I even found myself writing the comments or even reaching out to Hill offices saying, oh, yes, like you said, let me write rural, underserved, medically underserved, areas. Like it was
I've used
hard.
that one in the ground.
I've used medically underserved to the ground,
I hate to see y'all coming.
I hate to see it.
Yeah, and it's, again, yes, we can tell the facts till we're blue in the face. That's why getting more strategic. We've been collecting anecdotal information from our docs for some time now with real stories, right, attached, real patient outcomes from the beginning to the end. And I think that has proven to have some value, but also real examples, right? When Medicaid was under fire and still is. A lot of people don't know Medicaid fuels economies throughout the country. And it is literally the number one source of funding, in revenue in some of these areas. And when we talk about hospitals, programs, and clinics being at risk, we're seeing programs, closed down. Like, I don't know how many times we're having members are reaching out, or I'm seeing things on the discussion board about this program's closing, or, this sponsorship is over now because there's funding insecurity. And now when a hospital closes or when a program closes, that doesn't just impact, right, the hospital in itself. The hospital is full of all the different professionals in there, but also, right, the residents too now that are on rotation. So this, like you said, this is life or death. These people have gone to school and have spent endless amount of time training to be in these positions. So it's also just very emotional for the docs, for us too, as lobbyists too, or advocates. I think that also while we're trying to move the needle, as they say, and get our issues across, that it takes a personal toll as well. I think on us trying to, like you said, are we leaving our values on the table? Are we staying true to our core? So I think, yes, knowing your audience, going in with the appropriate amount of information, and knowing how to translate and kind of strategically change the course of the conversation based on knowing what that member, right, what they're talking about. So
I want to zoom out a little bit and talk more about why physician voices matter. You guys know I spent almost 7 years in health insurance, and
Mm-hmm.
then I had a stint in hospitals. I've never done the
Mm-hmm.
physician provider work before, and that's why I was just so excited to talk to y'all. And Christina, when we had our first conversation, you were talking about, some of the things that you tell the doctors that you represent about why advocacy is critical and how to like train them and get them ready for the conversation. I would love to know you guys' thoughts on just in general, what is at risk when policies are developed without meaningful clinician input, and how do you increase that input from to increase physician perspectives into what's happening now in DC?
Well, we could
I
see what.
mean,
Oh, go ahead,
go ahead, Nina. No,
Christina.
go
No,
ahead,
go ahead.
Nina.
I was just gonna jump in and just say something because I just got so upset, and I was like, "Well,
Crashing
measles,
out.
measles, measles,
Ooh.
measles.
Oh
Why do
my
we have
gosh,
measles?"
measles. Measles was gone. There was no measles. We didn't know her like at all. And
I
now
know. I don't want to know her.
I don't want to know her either. She can stay where she was at. She has no place here. I mean, really, what we're losing is accuracy,
Yeah.
science-based accuracy. I mean,
Mm-hmm.
which is what we're
Mm-hmm.
seeing with the vaccine debate. And I think that one of the conversations that I have with my physicians is they're always like, I don't know how to advocate. I don't know, can I be an advocate? I didn't get my master's of public health like you. I'm like, girl, you can be a better advocate than me. Like I'm not the
Mm-hmm.
one seeing the patients, and I don't want to
Mm-hmm.
be a broken record, but it really is just so important to tell these stories because I'm all of the misinformation. I mean, it is
Mhm.
still just, it boils my blood. It's mind boggling to me that we are still talking about this in relation of vaccines and the autism thing. That has been
Mm-hmm.
debunked a
Yeah.
million, trillion, billion.
Yeah.
Even the person that put out the initial study said that it
Mhm.
was inaccurate and that they didn't have
Mm-hmm.
Mhm.
the proper information. So to still be having people that are so strongly um, behind it, and then the recent changes to the vaccine recommendations and the
Yeah.
schedule, that's going to put us even further behind. I mean, that is terrifying for parents who can't, their kids aren't of vaccine age yet, who
Yep.
do have a choice and will get their children vaccinated, but they cannot get those vaccines yet. So,
Mhm.
to your latter point, Ryan, about, a lot of physicians are burned out, and that is something that I'm very passionate about, that I'm sure we'll talk about a little bit more with uh, how hopefully that can improve, and the effect of that, especially with HR1.
Mhm.
But whatever you can do to be an advocate, that is what you should do. If you don't have the time to go to the Hill, make a phone call, send an email,
Mhm.
offer
Mhm.
yourself to be a subject matter expert. Say, I am a
Mhm.
pediatrician from Little Rock, Arkansas, and I am seeing this in my rural health clinic. I work in an FQHC, and this is what I'm seeing.
Mhm.
I work in the ER, and because of the
Yep.
cuts to Medicaid, our ERs are going to be overfilled because people can't see their PCPs anymore because
Yep.
Mhm.
of workforce
Mhm.
requirements or other cuts. And that's going to be a really big issue of overcrowding ERs when we already have a shortage of ER physicians and
Mm-hmm.
ER
Mhm.
nurses.
Yeah.
Yes.
Um,
And our nurses.
attend a town hall. If you
Mhm.
can do that, do that. If you can call one of your legislators and say, hey, especially on a local and state level, because you
Yeah.
don't just
Mm-hmm.
have to go federally. On a local and
Absolutely.
state level, if you can call and say, hey, Representative so and so, let's have a cup of coffee. If you can, I've heard that a lot, especially from the local and state level, that they are a lot more open and sometimes available to have those face to face conversations. Maybe you
Mhm.
can meet me at the hospital and we can go to the coffee shop here. But there's always opportunity, and we know that you're tired and burned out and all of those things. But sharing your story is literally, as you guys have already said, life and death, not to be a broken record,
Mhm.
but it is life and death to get that information out there, for it to be
Yep.
accurate, science based information, not
Mm-hmm.
something that somebody's cousin came up with when they was just writing in their journal at 3 o'clock in the morning and had an
Mhm.
idea from Google.
Mm-hmm.
So,
Mhm.
and
Mhm.
just to plug
Mhm.
this as well, Chat GPT Health just launched last week. And
Yeah.
so that is even scarier on how misinformation is going to be disseminated.
Mm.
AI in healthcare is a big thing that we're
AI and
looking
health.
at right
That's a
now
big thing.
at
Yeah.
our organization. And I'm sure at your organization, I'm sure at all organizations. And so
Yep.
another means of a channel for misinformation is the very last thing that we need right now. So now
Yeah.
more than ever, we need not just the lobbyists, not just the advocates, we need the physicians and the patients to tell
Hmm.
their
Hmm.
stories. Continue talking. Even when people are tired of hearing you talk some more.
Yes.
No, absolutely. And to your point, burden, right? We hear
Yeah.
about administrative burden,
Yes.
burnout amongst physicians. So at the end of the day, the physicians see the downstream effects of policy every day, right?
Hmm.
Whether it's on
Hmm.
patients, workforce shortages,
Hmm.
outcomes, and so on. So without that perspective, we are missing so much. And well-informed policies definitely create well-intentioned policies can create unintended barriers or miss the
Yeah.
mark entirely. So that's why it's just so important that we have our physicians at the table. And to your point, Christina, too, we have physicians that say, how do I get started? How do I get into this? And
Mhm.
I tell them, like, you are better positioned than I am to speak
Hello?
on these issues. You went to med school, you did residency, you are, training faculty and are a clinician, like practicing. It doesn't get any better than that. And you understand
Yeah.
what it took to go through all of that training, the debt incurred from that training, which is another thing, right? That is a big agenda item after HR1 and so on. I too have loans, not medical school loans, but I
Me
have
too.
loans.
I too.
That
I too am a victim of the loan system in the United
Same.
States.
Same.
yeah. Some people will say, they've already forgiven their loans. So that's up to whomever else. But
Not my problem.
that's,
Yeah.
I unfortunately, yes, the loans are there, but it's important to have that perspective to really inform policymaking and not to go too far down the line when we talk about when physician voices aren't centered and actual
Mhm.
medical professionals aren't in the equation. Then we see, right, issues with the different advisory boards. Like we know the ACIP, the
Mhm.
Advisory Committee on Immunization
Mhm.
Practices, completely disbanded. And now one of the other boards that we are closely monitoring is the United States Preventative Services Task Force. So
Hmm.
and that committee also has not had any meetings recently, and we're all wondering what's going on with this. Is the same thing going to happen to this entity? They provide very important recommendations on healthcare, etc. Also, an
Hmm.
entity that is comprised with physicians and other faculty too. So it's just we are losing, to Christina's point, right? The science,
Yeah.
the evidence base, the experts. Don't
Yeah.
get me started on the workforce. How we done lost the
I
best
was
and
gonna
brightest in the
say,
workforce to the federal workforce.
Nina frequently crashes out about the work
oh,
Very quickly.
frequently often.
Ask the
I
next
know a lot
question
about it. Yeah.
so let's
But
move
see,
it
what,
along before it
right,
gets
but see,
crazy.
I
Before
want
I
to
get
say
mad.
is right. Before she gets is, caucuses, at the federal level are heavy on my mind this
Mm.
week for a bunch of different reasons. And but I'm wondering if you guys see any operational value. And we have the Republican dot caucus, right? And we have the
Mm-hmm.
newly formed the
Democrat.
Dem dot caucus as well, because
Mm-hmm.
there are physicians, members of Congress, right? We have them in the House
Yeah.
and the Senate. And so we have the Republican dot caucus, we have the Democrat dot caucus. I'm wondering if how you guys see the caucuses, and not just those. There are the nursing caucuses. There's healthcare short. There's all these
Yeah.
different caucuses on the Hill. Some are much more active and influential than others. I'm wondering how you guys see the influence that doctors and the medical community already has in members of Congress having as like a check and balance on what's happening broader in the administration. You talked about some of these task forces, things like that. What do you guys see happening this year? And can some of the caucuses help?
We can hope that these caucuses and groups, and even some of the working groups too, right?
Yeah.
Congress also puts together working
Yeah.
groups. Last year,
Yeah.
there was the year before, the bipartisan working group on GME, graduate medical education, and
Mhm.
coming out with policies over
Mhm.
there. But I think ultimately, too, yes, we have physicians and medical professionals in Congress, but speaking on behalf of myself, they're not all of them are actually representing, the best interests of this country when it
Mm.
comes to the people that really need the care, the vulnerable
Mm.
populations. the policies, when we talk about some, I won't get too far into DEI, but DEI, that bill was
Mm-hmm.
also brought forth by a physician. We know the importance
Mm-hmm.
of
Sure was.
having cultural
Mm-hmm.
competency in curriculum, and that we know that patients have better outcomes when they're treated by physicians that look like them, can understand their needs.
Mm-hmm.
So
Mm-hmm.
I do hope, and I think, we work with a lot of the docs in Congress, or the doctors in Congress, and I think that they have made some good, policies and
Mm-hmm.
recommendations. But the problem is, we have all the negotiations, but
Mm-hmm.
nothing's happening.
Yeah.
Everything,
Yeah.
there's so much stuff that's at a standstill. We're having these conversations
Yeah.
on this side of the aisle and that side of the aisle, but everything has been so stalled. I think that there is definitely utility. I was actually very impressed with that bipartisan working group
Mm-hmm.
a year ago, and GME is a very complex issue on the Hill, so it was a very
Hmm.
robust, policy framework. But I think that we are
Okay.
definitely going to have to.
Opportunity, bright spot.
Yeah, no, yeah. So yeah,
Yeah.
exactly. It's a bright spot. We have to hold on to those. I told someone on the call today, I said, micro joys to compensate for the macro grief. So
Oh,
we
no,
have to
that's
take the
right.
little, the
All
little,
right.
I'm saying, the little,
All
the
right
little
now.
bits, the little bits. You have to hold on to that. But I think that there definitely is utility in
Mm-hmm.
these caucuses and in groups, and I just really hope that we can work in a fashion, in a way this year, to really put forward some legislation that is really going to help the American people. And
Mm-hmm.
we are running on a deadline. So I'd
Mm-hmm.
like these caucuses, these groups, to get together in the next week or so.
Oh,
Yeah.
okay. Yeah. Christina, your thoughts?
Yeah. I mean, I'm right there with Nina. I, I I'm glad that she said it and opened that door, that we do have physicians up there, but what is really happening? I mean, even with,
Mhm.
I have been on the Hill for testimonies with my docs, and there have been docs that are in Congress completely refuting what they're saying, even though it's evidence
Mm.
based.
Oh,
So
wow.
it's almost
Yeah.
like you're actively working against what you originally worked towards. Your initial ambition wasn't to be in Congress, it was to be a
Mm-hmm.
physician. And now you're
Mm-hmm.
working towards the patients that you committed to serving. And
Mm-hmm.
so I think that all of us are burned out from luncheons and conferences and summits and all of we all know what work needs to be done. Who is going to
Mm-hmm.
step up and do it? And to Nina's point, there are some bright spots, but I think that I am a little cynical, just a little bit. And I'm just like, I want to see the work. I want to
Yeah.
see
Yeah.
where you are actually putting forth the effort. I mean, again, as she said, an actual physician put up the bill for DEI, removal of DEI, when we all
Mm.
know how important racially concordant care is. And I think it's
Mm.
just more important now than ever to see that these attacks are intentional, they
Mm. Mhm.
are pointed, and so
Mm.
we can't always rely on we can't just rely on these offices and these people just because they are also physicians,
Yeah.
or because they
Mm.
are the head of the nursing caucus or head of the
Mhm.
doctors caucus
Mhm.
or whatever, because they don't have all of our interests in mind.
Yeah.
They may have the interest in mind for the people that can afford health care, that make
Mm.
six figures, that have private insurance, but what about the people that don't? And that
Mm.
is where I am concerned of,
Mm.
what do we do for the people that cannot speak for themselves, the underserved
Mhm.
communities, as
Yeah.
Nita said. What about those people? Because we're talking about healthcare, but we're not just talking about healthcare for those of us who can afford it. We're talking about healthcare for everyone. And I think that for
Yeah.
everyone gets left out of the conversation, or it's only in the luncheons, it's only in the summits, it's
Mm.
only in the
Mhm.
conventions that you're talking about it in the mic on stage, but when you get back to your office on the Hill, what are you doing when you sit down with your staff? What are
Because
you
DC
truly bringing
loves
up?
a luncheon. DC loves a
Loves
summit.
it.
DC loves a briefing.
A
And to your
round
point,
table.
A
a
round
round
table, all
table.
of
Oh my
that,
We've been
gosh.
to
all of
a
that.
trillion and one of these things. And I think what I'm
Yeah.
hearing both of you guys say is that, like, one, just because there are elected officials who may be physicians holding these positions of power does not mean that they inherently have that they can really represent the needs of the physician body, right? Of the medical bodies. The second thing I'm hearing, just to reinforce this, is that this is why it's so incredibly important for physicians to put on that advocacy hat, right? And to tell their stories and to go to the Hill, because we need so many different perspectives. We need the data, we need the stories, we need the anecdotes, we need all these things, because it sounds like that's what's going to move the needle versus, resting on the laurels of, a Dem dot caucus or a Republican dot caucus, right? Like, we need to make sure that we're bringing more people to the table, in order to have the conversations and share the stories and talk about what is really happening on the ground.
Yeah, and I'm an equal opportunity critic. So, like you said, the Dem caucus, the Dem dot caucus,
Because
and the Republicans too, because get it together.
Yeah, because everybody can catch the
bipartisanship.
smoke. Let's get the work
Yeah.
done.
Because I too need health care. I mean, I have health care, but I'm
Absolutely.
saying, like, I too, like, we all are impacted in some sort
We are.
of way, or know people that are
I was just gonna
impacted,
say, or know
in
people.
some, in some sort of way. Like, we are not so far removed from this. And I think that too, also as a lobbyist too, because it's like, it's a curse too, being so educated and knowledgeable about these issues, and you can see the consequences and the outcomes before everybody else, because you're
Yep.
so knee deep in the text.
We're so
And
close
then
to it.
exactly, you're
Yep.
so close to it, and then you take a step out, zoom out, and hear the discourse, even among voters too,
Yeah,
etc.,
absolutely.
right? And you're like, huh? How did we get here? And then, and then Congress and the administration, it just doesn't help that the repetitive rhetoric is happening, and it's harmful. It's harmful,
Yes.
and it's dangerous, and people's lives are on the line.
Yeah, my family hates to see me sit down at the Thanksgiving table, because they're like, she's about to talk our ear off again about what we need to be doing, what we shouldn't be doing, and I sure am. I sure am.
Oh my gosh, yes.
So, ladies,
Yeah.
I feel like we can talk about this for hours. I think we need to have a
course.
part 2, 3, and 4.
Yeah.
Very soon.
I would love that.
That would be so fun. I want to
Yeah.
end with one lightning round question, and I feel like it may be a longer answer. So if we could keep it cute.
Okay.
If you can think of one, if you had a magic wand, right, and you could think of one single policy shift that would make the biggest difference for physicians and patients this year, what would that policy shift be? Magic wand.
A realistic one, or like my dream?
If you're your dream,
Magic wand, dream.
please give me a dream. I want a dream. Oh my gosh.
Oh my gosh. I would say realistic, or that's not even realistic. I would say overturning HR1. That's a huge one. I mean, I know that, because I don't want to get into the workforce thing, I'm going to keep it really cute, but that would solve just right there, that barrier of capping student loans at $200,000 when we already have such a shortage of physicians. There are a shortage of residency spots because 4,000 people can graduate from medical school, and there's only 3,500 spots. And Nina, I know this is going to activate.
Don't get me going on the slots.
I'm sorry.
I didn't get to talk about the slots.
I think I would literally be up at,
okay.
I would be up all night in my bed, like, why didn't I bring that up, if I didn't say anything about it? And so, I bring that one to the table because a huge thing is physician burnout. And so patients can't get help if there are no doctors. If doctors are now, before, doctors used to be like, I ain't retiring until ever. I'm gonna go to the grave still practicing. Now they're retiring at like 45, which you can't blame them.
Yeah.
But I would just say, whether that magic wand is making medical school free, whether that legislation or that magical wand is overturning HR1, and that way we also forget the Medicaid cuts and forget the caps on schools. So there's a lot of things I would love to do with the magic wand, but in terms of healthcare and health service delivery, I just think that would be huge to changing how we are able to provide care if people did not have to worry about medical school costs.
Yeah.
Nina?
Yeah, absolutely. So medical school costs, like you said, and permanent telehealth flexibilities.
Oh, that's
also,
good
we
one.
talk about
That's
access.
a good one.
Access, that's a big one, because I'm still waiting.
That's huge.
We're all still waiting, right, to making those
these permanent
flexibilities
flexibilities.
permanent.
Yeah.
This isn't something that we've been working on during COVID and then post public health
I was working on
emergency.
this in health insurance.
Yeah,
Yeah.
it's huge. It's so major for patients and for our physicians. When we talk
Yeah.
about, administrative or not administrative burden, but just burnout too.
Mhm.
Also, allowing also residents to be able
Mhm.
to come in and take care of certain level visits with, with the attending supervision or not supervision and so on.
Mhm.
And also for me, I mean, really truly investing in the workforce and obviously primary care, but teaching health center GME. And I won't go on and on about THC GME, but it's an incredible program, and it's been used to, it's a unique program, and it's really to help communities grow the healthcare workforce as for physicians as well as dentists, and they remain typically within community-based settings with a focus on rural and medically underserved areas. So these programs are critical to the workforce and continuing the primary care, the physician pipeline and so on, but reaching people in these communities, in these disparate communities across the country. So the THC program has not had consistent and sustainable funding since it came online in 2018, and is another program that has suffered tremendously over the course of the last couple of years with these continuing resolutions and forcing different residency programs to close and so on. And with when programs close, people lose their jobs. So really investing in these programs, health profession programs, Title VII funding for the, for the workforce, including the nurse health professions programs and so on. There are so many things, but I think real investment in the workforce shortages, I think, is one of the best ways, would be a major shift this year.
I just want to say, now you guys see why I said you guys have to meet.
Right.
For sure.
And
another thing.
Right.
And I just want to close out by saying that, like, I sleep better at night, and I'm sure everyone who is watching and listening to this podcast will sleep better at night knowing that we have you guys as advocates for physicians and for the healthcare workforce. Like, you guys are really laying the groundwork for the future that we need to make sure that everyone can get access to care. People can get the care when they need, how they need it, and it could just be for them. And I'm just so grateful for the work that y'all are doing. I'm always grateful for the policy related crash outs.
That means we're passionate.
You care and you're passionate, and I'm so grateful that y'all are the advocates, because I feel like we need this in the moment. So I'm going to do a wrap up, but I just want to thank you guys for that, because I think that having you guys on the podcast, I think, shows this level of passion and intentionality, and not only from NMA's perspective, but for the Society of Teachers of Family Medicine's perspective. And I know that there are so many other physician advocates for physician advocates that are just as passionate. And I think if we can sort of get more people to see it, shine a spotlight, then we can see that there are people who are working so hard to make sure that we can continue to live healthy lives and we can thrive well into old age. So thank you guys so much. Thank you, Christina. Thank you, Nina. You guys are absolutely phenomenal. And I cannot wait to continue this conversation, likely in person, very soon. I also need to thank Rex Wallace Consulting for sponsoring the show. Our partnership with Rex Wallace and his team helps make these conversations possible, and we just so appreciate the support. And thank you to everybody listening. I hope you enjoyed this episode. I know I did. Be sure to subscribe, share it with a colleague, and join us next time as we continue cutting through the noise in Washington, D.C. Until next time, I'm Ryann Hill, and this is Mic'd Up with Ryann Hill.
We all know quality isn't optional. Success in Medicare Advantage and Medicaid demands relentless focus, using data, engaging providers, elevating member experience, and embedding quality in your culture. At RWC, quality is our DNA. Our clients outperform the industry, and our Net Promoter Score of 94 says it all. Whether you're aiming for 4 stars or exceeding Medicaid benchmarks, redefining success in Medicare and Medicaid begins with RWC, because we catalyze cultures of quality.